you guys later.
Thank you.
You're welcome. Okay. So like she said, my name's Katie Russell. I work, right now I work on the, am I on the camera screen? Okay. I work on the PACU at Gateway, and before that I did 5 years in night shift on Med-Surg ICU. I have sat for the CMSRN certification course test, so I have had a certification. It's a little different than this one, but it's kind of the same principle where you're being tested on knowledge and you're showing like you exceed the knowledge level of a lot of nurses that you might work with on the unit. You've gone the extra mile and gotten certification. And I just want to say I think it's really important, and it's great that you're all here, and that if I can do it, everybody can do it, because I am not a test taker. So I'm not one of those people that could sit down and go through a test and not study at all and ace it. And even if I do study, I still struggle with tests. So if I'm a person who can do it, you're a person who can do it, okay? This is just going to be an overview of the pulmonary system. We're going to go through things pretty quickly. I only have an hour. We have some questions mixed in here. There's less people than I thought there were going to be, so we can be kind of informal. And you know, you can ask questions and all that and offer things if you have things to add. I'm going to be taping the first portion of this just for a school project. I'm getting my master's in nursing education, so that's why I have that camera there. And we'll go ahead and just start off. What is the approximate O2 concentration of a patient receiving 3 liters of O2 per nasal cannula? Anybody want to make a rough estimate? What'd you say?
93, 94%?
No, that's pretty high. When you think about it, a non-rebreather, we're trying to offer them as much oxygen as we can, almost getting them up to 100% FiO2 as much as we can without getting invasive. So a 3 liters nasal cannula, we're not going to be near as much as that.
11%?
Around 30%. Yeah, and I don't know if I'd spend that much time studying percentage-wise, just to kind of give you a hint. Room air is like 20, 21%. Then you start going up incrementally at slow doses, so like 2 liters is 27%, 3 is 30%, 4 is 33%. So that's just some kind of basic knowledge. I don't think you have to know that for the test, but it's good to refresh your memory. And then, what is the most common cause of airway obstruction in an unconscious patient?
Tongue.
Tongue, exactly right. Yep, tongue. Okay, so for assessment purposes, obviously you're not going to be assessing a person on this test, but they will probably put like assessment findings in the question, and you'll have to like figure out what the answer is based on the information they give you in the question. So a lot of times you do hear assessment findings. Of course, you want to review the breath sounds. You also want to review how you assess a patient for lung sounds. So obviously we listen to anterior, posterior, laterally, and we go right, left, right, left, right, left, because we're comparing the lung sounds on the right side and the left side. You want to be able to classify each sound according to intensity, location, pitch, duration, and you want to note whether sounds are occurring during inhalation and exhalation, because that can maybe give you a hint as to what the answer is when you're hearing the breath sound. Physical assessment, of course, you're going to be noting all the outward signs, colored lips, earlobes, mucous membranes. You want to also assess like how are they positioned, because that can also give you a hint in the question as to what they have. So if they're sitting in a tripod position, you might want to be thinking that's like an emphysema pose, COPD. So sometimes the positioning of the patient is going to give you a hint. Patient's level of consciousness, are they awake, anxious, breathing rapidly, are they attunded? So like an attunded patient, this might be an emergency situation. So if they're asking you what are we doing on an attunded patient, we're probably not going to stick them on nasal cannula. That patient's not moving and not responding. This seems like an emergency situation, so your intervention is going to reflect that this is an emergency. And so those are the kind of things they might give you in the questions that you have to respond to. You also want to note the chest appearance. Do we see obvious signs of trauma, anything like that? And then observe the respirations. rate, depth, rhythm, accessory muscle use. Are you seeing paradoxical chest movement where like the stomach and the chest are going opposite? When you take a breath, your whole chest should rise. But if you see if their chest goes up and their stomach goes down, and then the stomach goes up and the chest goes down, that probably means obstruction. That's probably a tongue's in the way. You need to lift their chin, get that airway open, get them breathing. So that can give you hints as to what you need to do in the question and what your answer is going to be. Okay, so our first condition we're going to review, bronchitis, inflammation of the large airways and hypersecretion of the mucose in the bronchial tree. Chronic bronchitis is a type of COPD characterized by a productive cough for at least 3 months out of the year or 2 or more consecutive years. So signs and symptoms, you might see accessory muscle use, anxiety, depression, chronic productive cough of thick, tenacious sputum that isn't clear. Cyanosis, dyspnea, decreased activity tolerance, decreased breath sounds, diffuse wheezes and crackles and bronchi, just not going to sound very good. And you may see signs of right-sided heart failure in these kind of patients. We're obviously going to have to do diagnosis and treatment. We're going to be doing chest x-rays, pulmonary function test, ABGs, complete blood count, electrolyte count, echocardiogram, and sputum analysis. And you'll find as we go, like that's like the panel that you do on all respiratory illnesses. It's like that's your basic thing that you start off with. We can treat with inhaled anticholinergic and inhaled beta-2 agonist. So the anticholinergic are like Atrovent and Spiriva, and then the beta-2s are albuterol, Zopanex. Those are kind of mainstays. If there's anything you want to review on this, because you've treated this before, you've seen patients like this before, so the nursing interventions may be kind of old hat to you, but the medications and the classes of medications might be worth reviewing. I know a lot of us give the medications and we recognize what we're giving, but like as to like the class and the use that that class has in this disease, you might be a little fuzzy on. So if there's any question on things you want to review, I definitely review the medication classes and what those classes are used for. And then nursing care, you're given the oxygen, you're providing adequate hydration to liquefy these secretions, physiotherapy, of course, smoking cessation. We're always going to do that for almost every condition. And then, of course, recommend yearly influenza and pneumonia vaccines if they haven't gotten those. Asthma, chronic reactive airway disorder that involves episodic reversible airway obstruction resulting from bronchospasms, increased mucosal secretions, and mucosal edema, characterized by airway inflammation, intermittent airflow obstruction, and bronchial hyperresponsiveness. These people can get sent off by too much activity. Environmental factors can set them off. So we've all treated asthma. And again, you probably know the signs and symptoms of asthma, but you want to look at the medications for asthma. A lot of times they'll like to ask you like, oh, a patient's come in with the acute exacerbation of asthma. What inhaler would you give them? So that's going to take a knowledge of what's your quick actors, what are we taking, continuously to maintain their airway on a continuous level, but then what do we give them for the fast acting relief? So generally asthma medications are put into 2 categories: quick relief for immediate symptoms, and the long acting medications to control the underlying inflammation. So quick relief bronchodilators are like the albuterol inhaler. You have the quick relief anticholinergics, which is like the Atrovent. Corticosteroids, sometimes they're used, some people use them all the time. Sometimes it's more of also a quick relief thing. Prevents exacerbation and progression during moderate to severe attacks. So it might not help with the attack per se, but it might help keep the attack from getting worse. And those might include Flovent, Palmacort. Those are the corticosteroids. And also prednisone is also used. And then long-acting beta agonist or combination drugs like Advair or Symbicort. Those are the ones we use daily for long-term control. You also might have Singulair or Spiriva. So if there's anything you want to review here, I definitely suggest reviewing the medications and how, you know, there's like an art to it almost. There are certain drugs they're supposed to take at certain times of the day. So you want to know what the long-acting and the short-acting and the quick emergency inhalers are and all that. And then, of course, you know the nursing interventions, give their prescribed medications, high Fowler's position, encourage pursed-lip breathing, humidified oxygen, don't let them get dehydrated, and keep room temperature comfortable for these people. So here's an example of what they might ask you on the test. A patient with acute asthma showing inspiratory and expiratory wheezes and a decreased forced expiratory volume should be treated immediately with which class of medication?
Bronchodilators.
Yes, the bronchodilators are the first line because bronchoconstriction is the cause of the decreased airflow. And then you just go through option A, beta adrenergic blockers, that causes bronchoconstriction, so we're not going to use those. Inhaled or oral steroids are given to reduce inflammation, but they are not going to provide emergency relief. So you might use those medications on an asthma patient, but they're not going to be your rescue inhalers that you're going to use for this immediate problem. COPD, you know, it's kind of like, COPD is like kind of a cover-all diagnosis. It covers several different things. First one, emphysema, impairs ventilation by decreasing lung elasticity, collapsing small airways during exhalation and trapping air, causing poor gas exchange in the alveoli. So common signs and symptoms, accessory muscle use, anxiety, depression, and that diagnosis comes with all of these, you know, with all these problems. You know, it's kind of hard to be happy if you're not breathing all the time. Characteristic patient positioning, which is the leaning forward, putting your arms up, tripod position, is common with these guys. Dyspnea, fatigue, pursed-lip breathing, and hyperventilation. And then, of course, the same diagnoses. We're going to chest x-ray, pulmonary function, ABGs, sputum analysis, all the kind of same cover-all things we do. Get them immunized against the flu, get them to smoking, get them to stop smoking, and keep them hydrated so that they can keep these sputum liquefied so they can cough it up. Also, one thing to encourage with these people, instruct patients with this to eat small, frequent meals to prevent constipation and avoid gas-forming foods, because that bloating is going to push up on their diaphragm and it's going to make it harder for them to breathe. So in normal patients, well, you know, normal, in patients that don't have COPD, inspiration is the most work of breathing. So we expend the most amount of energy taking breaths in, and expiration is a passive movement that just happens naturally. We're not using energy to exhale. A normal drive for respiration is high CO2 levels. But in patients with COPD, just keep in mind, they use energy to inhale and exhale. So they're having to use double the amount of energy to breathe. Muscles are stretched and don't contract well. They get air trapping, and the respiratory system wears out, and only a low O2 level drives their respiratory rate. So that's why you get patients where the doctor says it's okay for this patient to be statting 88 to 89. We don't have to keep them high, because if we get their oxygen level too high, we'll actually decrease their respiratory system drive to breathe. So that's why these patients are a little bit different. Labs, Red blood cells may be elevated because our body's response to hypoxia